was done and epinephrine was given. And after epinephrine was given, this is what was seen on the monitor. Okay, you can see that the heart rate comes back, but the patient is still hypotensive, but now the heart rate is 288. Can someone tell me what this rhythm is? How is this different from the sinus tachycardia that the patient presented with? Anyone? Yeah. Dr. Ola, I'm seeing 2 responses now. Well, okay. If you're Maude and Dr. Ola says, this is SVT, and in SVT, you cannot see the P wave, and then the heart rate is usually above 220 in an infant and above 180 in a child. So this is SVT. So on your guidelines, what do you do? How do you treat SVT? Anyone? Anyone? Adenosine, good. So you give adenosine, okay? Adenosine was given in this case. What is the dose of adenosine to be administered? Okay, I'm seeing vagal maneuvers, okay? Okay, that's all correct. So vagal maneuvers and adenosine. Okay. What kind of vagal maneuver would you perform in this child? And what if you gave adenosine and you did vagal maneuver, but the child is still hypotensive and still tachycardic, still in SVT? What else can you do? Okay, adenosine was given, but there's no response. What else can you do? No, we cannot do procainamide yet. What else can you do? Repeat adenosine, yes. I will repeat adenosine at the higher dose. You repeated adenosine at the higher dose. The patient is still in SVT, and I'm also seeing amiodarone, okay? Yes, Dr. Lufisaya said synchronized cardioversion. Yes. Anytime you have a patient who is in symptomatic SVT, which means SVT with evidence of poor cardiac output, as shown in this case with a low blood pressure, and if you check the capillary refill is prolonged, even though you can give adenosine, you should be ready to shock the patient. And the type of shock is synchronized cardioversion. So what I'm going to do now, I'm going to demonstrate how to do synchronized cardioversion. So first of all, what energy level are we going to use to shock this patient? What is the dose? Let's assume that this baby is 10 kilograms. You can look at your pulse card. 2 joules per kilo, okay. Somebody says 5 to 10. Any other ideas? Any other ideas? Okay, the correct dose is 0.5 to 1 joules per kilo. Yes. 0.5, Dr. Adigun, 0.5 to 1 joules per kilo. So let's show. Now, it is synchronized cardioversion because you don't want to shock the patient. You don't want to deliver the shock during the cardiac cycle, during repolarization. You don't want to shock the patient on a T wave. So it has to be synchronized. So what's going to happen now, I'm going to demonstrate that. Just look at the monitor. You can see I'm selecting the energy level. Okay, where this child is 10 kilograms, so we're going to do 0.5 joules per kilo, which is 5 joules. We're going to charge. Okay. You charge and then you sync. Can you see on your EKG, can you see all the dashed lines? That is the syncing. And then now we discharge. So you shock him back to sinus rhythm. You can see he's back in sinus rhythm now. After you deliver that shock. And look at this sinus rhythm. You can see the P waves clearly compared to the SVT where you cannot see P waves and the heart rate was about 280. But this child is not out of trouble yet. For those who said inotropic support, so at this point in time, you can start epinephrine. I probably will not give any fluid at this point. What if this child is now doing this? What kind of rhythm is this? Anyone? Okay, I'm seeing ventricular fibrillation. Somebody says ventricular fibrillation. Any other ideas? Ventricular tachycardia. I think yes. Ventricular tachycardia. How will you treat ventricular tachycardia with poor perfusion? Look at your look at your algorithm, please. Can somebody mute their phone, please? Look at your algorithm.
Hey, what do you need? Come on, what's that's it.
Okay. Ventricular tachycardia with poor perfusion, as in this case, low blood pressure. You treat that patient like SVT. You do synchronized cardioversion. So we're going to do that again. We will charge the monitor and the energy. Anytime you are doing synchronized cardioversion, the energy level is 0.5 to 1. That is the recommendation. Occasionally we go to 2, but the standard recommendation is 0.5 to 1 joule. So if you do 0.5 per kilo and it doesn't help the child, then you can go ahead and do 1 joule per kilo. So let's do, you charge the monitor, you sync. Again, you can see the dark sign on your monitor. Please, when you want to shock any patient, once you engage the defibrillator, you have to make sure nobody is touching the device or the bed so that you don't shock your colleagues. So you do this is VTAC with poor perfusion. So you are doing synchronized cardioversion and you deliver your energy level. Okay. Now, the child now went from this to this. Can somebody tell me, this is still VTAC, but what is the difference? I'll go back again. The last reading is VTAC with low, very poor pulse and low blood pressure. You synchronized, shock the patient, but he went into VTAC this time. What can you see on the monitor? Anyone? Okay, I'm seeing ventricular fibrillation. No, this is still VTAC, but there's a difference between this VTAC and the one we just saw. Thank you. This is VTAC without a pulse. So Dr. Lufisayo said this VTAC without a pulse, how will you do it? Can you mute your phone, please? VTAC without a pulse. Okay. If you look at your pulse, when you are dealing with VTAC without a pulse, there's a lot of background noise coming from somewhere. And someone moved their phone. Okay, what is the difference between VTAC with a pulse and poor perfusion and VTAC without pulse, which is what we are seeing on the screen right now? There's a basic fundamental difference. So I'll just say pulseless VTAC. Pulseless VTAC is treated like ventricular fibrillation. So even though this is VTAC, all right, so let me show you ventricular fibrillation because I think it has caused confusion. This is ventricular fibrillation. You can see that in ventricular fibrillation, the tracing is more disorganized. And when the heart is fibrillating, it's just contracting. You can count the heart rate, but it's not doing anything. That's why in ventricular fibrillation, there's no cardiac output. The cardiac output is 0. So the patient doesn't have a blood pressure and the patient has no pulse. But this is ventricular fibrillation. Let's go back to ventricular tachycardia and see the difference. you can see ventricular tachycardia is a more organized reading. But then if the patient has no pulse, even though the readings are different, VTAC without a pulse appears different from ventricular fibrillation on the monitor. But according to the pulse guidelines, the treatments are the same. Because in pulseless VTAC, you have no pulse. In VFib, which is the next one I'm showing you, you have no pulse. So what you are supposed to do is to shock the patient. This time, you are doing defibrillation. In defibrillation, the first dose is 2 joules per kilo. Unlike synchronized cardioversion, where you use a lower energy level to start with, which is 0.5 to 1 joules per kilo. Again, I repeat that. When you are doing synchronized cardioversion for a patient with SVT or a patient with VTAC with a pulse, you start out with a low energy level like 0.5 joules per kilo up to a maximum of 1 joules per kilo. But if you are doing VFib or VTAC without a pulse, you start out with a high energy level, and that is 2 joules per kilo. And in that case, you do not have to synchronize. So there's a difference between defibrillation and synchronization. In defibrillation, you start with a high energy level. In synchronization, you start with a lower energy level. And in synchronized cardioversion, the energy level is lower. And like I said, you have to synchronize. So in this case, since the patient is 10 kilos, we're going to start with 20 joules. Okay, you charge the monitor and you shock the patient. Okay, we're applying the shock now. Once you apply the shock, then you start CPR. That's CPR. Again, when you are doing CPR, we are doing chest compression at 100 to 120 compressions per minute. And the compression to ventilation ratio is 15 to 2. Once you shock the patient and you do CPR, then you start to give your adrenaline. If you give that, then you go back to shock CPR, you give adrenaline again. If the patient doesn't respond, then you can use other medications like amiodarone or lidocaine as shown on your past record. So we are doing CPR now at 111 compressions. You give epinephrine, etc. Now, this reading that I'm going to show you here. Now, what reading is this? Anyone? This reading is also ventricular fibrillation, but this is fine, like FINE, fine VFib. The one I showed you earlier is coarse VFib. Okay? You can see coarse VFib and then fine VFib. That's coarse VFib. And this reason is fine VFib. For VFib, shock once, about 2 joules per kilo, start chest compression. Compression to ventilation ratio is 15 to 2. Give epinephrine. If you have to shock the second time, then you go to a higher energy level. So in this case, we started at 2 per kilo, and the patient is in fine VFib. If I have to shock the second time, I have to go to 4 per kilo, which would be 40. So I increase that to 40. Okay, this thing will not go up to 40, but it's jumping. I go up to 40, I charge. and I discharge my energy level. And then you do CPR. If the condition continues, you can go up to 10 joules per kilo. So I will repeat, when you are defibrillating, you start out with 2 joules per kilo. Initially, you give one shock, 2 joules per kilo, start CPR. If the patient does not respond and you have to shock again, you go to 4 joules per kilo. If the patient doesn't respond, you keep increasing your energy level to a maximum of 10 per kilo. Okay? Now, if you are dealing with a teenager who is adult size, then you cannot do per kilo per kilo. Just start at about 200 joules and you keep increasing that. So let's move on. What is this reading? What is this reading? Anyone? Yeah, this is asystole. In asystole, your first response is to start CPR, because in that question they were trying to see if you can get if you know the order of response. So this is you are doing chest compressions. And you are doing chest compression at 110 to 120 compressions per minute. The compression to ventilation ratio is 15 compressions to 2 ventilations if the patient is not intubated. And then you're also given epinephrine. You need to know the dose. During asystole, you need epinephrine to restart the heart. You give epinephrine. And then you keep doing CPR. Then you can give saline boluses. You can correct electrolytes. But your first response in asystole is to start high quality CPR, which means chest compression at 15 compressions to 2 ventilation cycles, and you are compressing at 100 to 120 compressions per minute. And you must rotate the person during the compression every 2 minutes. And you give your epinephrine or your adrenaline every 3 to 5 minutes until you can get the patient back to sinus. So in this case, after doing CPR, he's back in sinus reading. And then for some reason, it goes back into SBT. But you can see the difference between the SBT in this case. Can anybody tell me the difference between the SBT where we are right now and the SBT that I showed you earlier on at the beginning of the case? Any answers? Well, yes, BP is normal. So this is a stable SBT. In this case, you do not have to shock the patient. You do not have to do synchronized cardioversion. You can do adenosine, and you can also put ice on the face. If this was an older child where you can see the neck, you can do carotid massage. And medications that we can use to treat SVT can be amiodarone. At times we can use beta blockers, but I don't want to go into the details of treatment. The purpose of this is to recognize the common abnormal readings and how to treat them. So there's a difference between SVT with perfusion and SVT without perfusion. So I'm going to show you what you are looking at on your screen is treatment that you can use for patients in SVT. But depending on whether or not you have evidence of this, I'm going to actually take this off for now because there's something that is missing. Let me show you this one instead. Okay, this is the treatment algorithm for SVT. Is shock present? If your answer is yes, shock is present, you should be ready to do synchronized cardioversion. Even though you can do other things like give adenosine while you are getting your defibrillator ready, but ultimately the treatment for SVT with evidence of shock, like your patient, is synchronized cardioversion. If shock is not present, like the one I just showed you, you can just do vagal maneuvers and also do adenosine, and you can increase the dose of adenosine as appropriate. Okay. So now we've gotten back to sinus reading finally. The next two, because of time, I'm just going to go over that EKG with you. This is first degree block, and the way you know that is look at the distance between your P wave and the beginning of your QRS complex. So the PR interval is prolonged, but it's constant. This is first degree block. You don't have to do anything about that. In one of the questions, they were asking whether to give atropine or transcutaneous transcut facing. This child is in third degree block, and you can see the PR interval is prolonged and the P waves they are not synchronized with the QRS complex. In the PALS algorithm, you are allowed to do atropine while you are getting ready to do transcutaneous pacing. That was one of the questions that was asked to you. The other thing I want to show you that is very fairly common, it's premature ventricular contraction, that's the PVC. On this tracing, you can see a normal QRS complex, and you can see this wide, bizarre looking. Those are all PVCs. If a PVC is just a single PVC, it is considered benign. But if you have multiple PVCs, as in this case, they can easily go to VTAC. So you need to find out why the patient is having PVCs. I will show you this on an EKG monitor here. So on the one above, you can see a normal QRS, and you can see the PVC, another PVC, a normal QRS, another PVC. But in the graph, in the EKG tracing below, B, you can see QRS complex followed by 1 to almost 4 rows of PVCs, which can develop into VTAC. So if you have multiple rows of PVCs, you need to be worried about that. And finally, before we go to, because of time, can somebody tell me what this is? And I will give you a hint if you focus on the T wave, which is almost half of the QRS complex, the amplitude. Any ideas? Yes. What is, if Dr. Effioma says tall T wave, yes, that's correct. So what does that suggest? Yes, hyperkalemia. Okay. So at this point, I want to go over some of the, are there any questions to begin with? You can write your questions or you can just talk to me. Okay.
Hello, sir.
Yes.
Thank you, sir. So, what about second-degree heart block? Is there any treatment for it?
Second-degree heart block, yes. Just like first. At times you have to, they are not responsive. It depends on what type of second degree you have. If you have the Winkeberg type 1, that's not considered a serious one. But anything type 2 and third degree, the patient has to be treated. In the PALS guideline, you can give atropine initially, otherwise you have to use a pacemaker, like transcutaneous pacing. If before then, at times we also used to use an alpha agonist like has got isoproterenol, but those are temporary treatment. The isopril or the transcutaneous pacing, invariably this patient might need pacemaker if it's like a, if you have impairment of the conduction elements in the pathway. For example, if you have sinus node disease, or if you have the ventricular conduction fibers, His bundle, if all those are impaired, something has to be done other than just medication. But in the PALS guideline, you can give atropine, isoproterenol, anything that has very good alpha agonism that can beta, I meant to say, that can stimulate the heart. You can use. Other than that, it has to be pacemaker. I want to now go back to all the questions that we did at the beginning and go over all the answers so that before we close. Are there any other questions before we start doing that? And this time I'm asking Dr. Olafimiha to help us read the questions. So I'm going to go straight into, so that we go over and then we can close. Okay, you should be able to recognize some of the answers now. Who is going to read this to us? Dr. Olafimiha, can you? Because I'm beginning to lose my voice. I need someone to volunteer so that we can go over the questions together. Anyone? Can you see the screen? Hello?
Yes, sir, we're here.
Yeah, I need someone to read. I want to go over all the questions now with your group. And then in the process, I can tell you my observations too during the case scenario.
Okay, so I can read.
Okay, go ahead. Who is?
Okay, so CPR pharmacology, Select the single answer for each question below. So number 1, which statement is correct about the use of calcium chloride in pediatric patients? A, routine administration is not indicated during cardiac arrest. B, it has the same bioavailability of elemental calcium as calcium gluconate. C, it is indicated for hypercalcemia, hypokalemia, and hypomagnesemia. D, the recommended dose is 1 to 2 milligrams per kg.
Okay, so here the correct answer is A. Is A. They are just trying to test whether you know the difference between the old PALS guideline and the new one. In the previous guideline, calcium chloride was administered during CPR regardless, but now it's no longer routine administration is not advised. Every other thing that they said there is not true. Calcium chloride, when you compare calcium chloride to calcium gluconate, calcium chloride has more elemental calcium than the gluconate, so B is wrong. Calcium chloride is not indicated in hypercalcemia. It's indicated in hypocalcemia, hyperkalemia, and hypermagnesemia. They're just trying to confuse you there. And then when you look at the dose, if you have to give calcium chloride, the standard dose is 20 milligrams per kilo, not 1 to 2 milligrams per kilo. So I'm just going over the wrong, why the other answers are not correct. But to answer this question, routine use of calcium chloride is not advised during CPR, except you have a patient that has low calcium or high potassium or high magnesium. And if you have to give it, the dose is 20 milligrams per kilo. So next question, please.
Okay. Number 2, which statement is correct about the effects of epinephrine during attempted resuscitation? A, epinephrine is contraindicated in ventricular fibrillation. B, epinephrine decreases myocardial oxygen consumption. C, epinephrine decreases peripheral vascular resistance and reduces myocardial afterload. D, epinephrine stimulates spontaneous contractions when asystole is present.
Okay, so the correct answer here is D. Everything else that from A to C is incorrect. Epi is used anytime you hear start CPR. For example, in the questions and in the case when you have VFib or pulseless VTAC, you shock the patient, you start CPR. Anytime you hear start CPR, that means you are taking the following steps. You are doing chest compressions, and your compression to ventilation ratio, if the child is not intubated, is 15 compressions to 2 cycles of ventilation. 1, 2, 3, 5 to 15, then twice. You go again. And then once you are doing that, you also administer epinephrine. So epinephrine is the standard drug for any CPR situation. Now, epinephrine actually increases myocardial oxygen consumption. Why? Because when you give epinephrine, it stimulates the heart. It has both alpha, beta 1, and beta 2. The beta 1 is cardiotonic, causes increased cardiac contractility, and anytime the heart is beating very fast, the cells consume oxygen. So that's not true. Epinephrine decreases peripheral vascular resistance. It's the opposite. Because it has alpha effect and causes vasoconstriction, it actually increases vascular resistance and increases afterload. So it's kind of the opposite. And of course, D is the correct answer. So let's go to question number 3. Question number 3.
Yes. Okay. Question number 3. Paramedics are called to the home of a 1-year-old child. The initial assessment reveals a child who responds only to painful stimuli and has irregular breathing, faint central pulses, bruises over the abdomen, abdominal distension, and cyanosis. Bag mask ventilation with 100% oxygen is initiated. The child's heart rate is 36 per minute. Peripheral pulses cannot be palpated, and central pulses are barely palpable. The cardiac monitor shows sinus bradycardia. 2 rescuer CPR is started. Upon arrival to the emergency department, the child is intubated and ventilated with 100% oxygen, and IV access is established. The heart rate is now 150 per minute with weak central pulses but no distal pulses. Systolic blood pressure is 74 millimeter mercury. Which intervention should be provided next? A, amiodarone 5 milligram per kg IV. B, atropine 0.02 milligram per kg IV. C, rapid bolus of 20 mils per kg of isotonic crystalloid. D, epinephrine 0.01 milligram per kg IV.
Okay. If you look at this question now, it cannot be amiodarone. Why? Because the kid was initially in sinus bradycardia, and now his heart rate is 150 per minute, so it's kind of like sinus stack. Atropine is not indicated in sinus tachycardia. There's no reason to give that. And this kid is not in VFib, and it's not in pulseless VTAC either. So there's no need for amiodarone. So what makes sense here, now that the child heart rate is now 150, is to give fluid, which is some of the things we do during CPR. Once they tell you 2 rescuer CPR is started, that means somebody is compressing the chest, somebody is bagging the patient, and they must have, if they are following pulse, they must have administered epinephrine as well. That's why the heart rate jumped from 36 to 150. So at this point, what makes sense is to give fluid. Okay. So the decision here is it C or D? And I don't see any benefit giving epinephrine to this child when my heart rate is already 150. Because even though it's not stated in the question, I'm sure once they start CPR, chest compression, they probably have given 1 round of epinephrine. That's why the heart rate went from 36 to 150. So the next thing that needs to be done here is to restore intravascular volume. And they give you a hint. The blood pressure is still low for that child. It's a 1-year-old child. And he's already gotten epinephrine. So the next possible thing to do would be to give fluid. So that the correct answer there should be volume. Okay, question number 4. That one should be quick.
Okay, so a 9-year-old boy is agitated and leaning forward on the bed in obvious distress. The patient is speaking in short phrases and tells you that he has asthma, but does not carry an inhaler. He has nasal flaring, severe supraspinal and intercostal retractions, and decreased air movement with prolonged expiratory time and wheezing. You administer 100% oxygen by a non-breathing mask. His SpO2 is 92%. Which medication do you prefer to give this patient? A, albuterol, B, adenosine, C, procainamide, D, amiodarone.
Yeah, I think everybody should get, because none of these other medications it makes sense for treating asthma, correct? So A should be the appropriate answer there. So let's move on to the next question. Okay.
So number 5, You're part of a team attempting to resuscitate a child with ventricular fibrillation, cardiac arrest. You deliver 2 unsynchronized shocks.
Okay, just hold on. Can you hold on there? You can see there that during ventricular fibrillation, the shock is unsynchronized. Okay, compared to when you have SVT with poor perfusion, or when you have VTAC with poor perfusion. So for VFib or pulseless VTAC, it is unsynchronized. And that is, you can also call that defibrillation. And the energy level is usually higher, starting with 2, and you can go to 4 to a maximum of 10. Please, can you read on?
A team member established IO access. So you give a dose of epinephrine, 0.01 milligram per kg IO. At the next rhythm check, persistent ventricular fibrillation is present. You administer a 4 joule per kg shock and resume CPR. Which drug and dose should be administered next? A, atropine, 0.02 milligram per kg IO. B, epinephrine, 0.1 milligram per kg IO. C, amiodarone, 5 milligram per kg IO. D, magnesium sulfate, 25 to 50 milligram per kg IO.
Okay, so you can see that atropine is not indicated for treatment of ventricular fibrillation, so that is wrong. Epinephrine can be used, but they give you, to let you know that that is not what they want you to use. They give you the wrong dose. Instead of, it should be 0.01 per kilo. If you look at the body of the question, they have already given a standard dose of epinephrine, 0.01. You can see there in the question, the body of the question. So there's no point repeating a higher dose of epi, which is no longer acceptable in modern CPR. In the old guidelines, there was a suggestion that if you start at 0.01, you can increase the dose 10 times and go to 0.1. We no longer do that, so that's wrong. So the next drug that will be useful here will be amiodarone. Okay? We do not use magnesium sulfate for VFib. The other questions where magnesium sulfate is the answer, I will explain that when we get there. So the correct answer here is amiodarone. Next question.
So number 6, which statement is correct about endotracheal drug administration during resuscitative efforts for pediatric patients? A, the intravenous drug dose should be used. B, it is the preferred route of drug administration. C, it is the least desirable route of administration. D, the drug dose used is lower than the intravenous dose.
Okay. You all know that in the past,
yes, sir.
Dr. Shubu, please.
Okay, you all know that in the past guidelines, there are 3 ways of delivering drugs. You can give it IV if you have IV, and you can give it IO, intraosseous, if you do not have an IV. If you do not have an IV and you do not have an IO, you can actually administer the drug through the endotracheal tube if the patient is intubated. So what this question is asking you is whether you know the difference, between intravenous or IO administration versus endotracheal administration of drugs during CPR with respect to the dose. So let's go over the alternative now. A, can you go ahead?
The intravenous drug dose should be used.
Okay.
It is the preferred route of drug administration. It is the least desirable route of administration. The drug dose dose used is lower than the intravenous dose.
Okay, let's start from that. When you decide to use the ET tube as your route of administration, you actually use a dose higher than the intravenous dose. So for example, if I have to give epinephrine through the ET tube, instead of doing 0.01, I would do 0.1. So that answer is wrong. C is the correct answer. If possible, we do not like to use endotracheal tube as means of delivering drug, but if you are cornered and have no choice, that's when we do it. So C is the preferred answer there. D, B, for the reason which I already explained, and A, I already explained that the intravenous drug dose should be used is incorrect. You actually have to use a dose higher than the intravenous. Okay, next questions here. Okay, go ahead.
Okay, number 7.
Mm-hmm.
I'm not seeing it very well here. Okay, so a previously healthy infant with a history of vomiting and diarrhea is brought to the emergency department by her parents. During the assessment, you find that the infant only responds to painful stimulation. The infant's respiratory rate is 40 breaths per minute, and central pulses are rapid and weak. The infant has good bilateral breath sounds, full extremities, and a capillary refill time of more than 5 seconds. The infant's blood pressure is 85 over 65 millimeter mercury, and glucose is 30 milligram per DL, that's 1.65 millimole per liter. You administer 100% oxygen via face mask and set an IV. Which treatment is the most appropriate for this infant?
Okay. I like, hold on, please.
Okay.
I like this question because it teaches you what to look for when you are doing a cardiovascular evaluation of a child. So this child, looking at the question, appears to the child in compensated shock because his blood pressure is normal, but his perfusion is poor. So that's why they are telling you that he has prolonged capillary refill time, more than 5 seconds. The normal capillary refill time should be less than 3 seconds and brisk. They are also telling you that the pulses are rapid and weak. And they're also letting you know that the patient has hypoglycemia. So you should be thinking of how to resuscitate a child with compensated shock, hypovolemic shock, and the patient who also has hypoglycemia. Can you please read on?
Okay, so the options: A, administer dextrose, 10% dextrose in water, 20 mils per kg bolus over 5 minutes. Administer 50% dextrose in water, 0.45 half saline, yes, 20 mils per kg bolus over 15 minutes. C, administer lactated Ringer's solution, 20 mils per kg over 60 minutes. D, administer a bolus of isotonic crystalloid, 20 mils per kg over 5 to 20 minutes, and also give 25% dextrose in water, 2 to 4 mils per kg IV.
Okay, so the correct answer here is D, because this patient is now getting an isotonic fluid. Anytime we are resuscitating a patient, regardless of what the serum sodium is, we do not give D10. We do not give hypotonic fluid, a fluid that has no sodium in it. So option number 1, which is just plain D10, is not correct. Option number 2 is not correct for the same reason. It's giving D50 and half normal saline. We need normal saline. Option number 3 is not correct because it's not addressing the hypoglycemia. Ringer's lactate is an isotonic fluid that you can use for resuscitation if there's no hypoglycemia. But in this case, they want you to treat hypovolemia and hypoglycemia. So the correct answer here is the isotonic crystalloid 20 mils per kilo and dextrose in water, D25 and 4 mLs per kilo. So that's the correct answer. Let's go to the next question.
So before then, we actually discussed this particular scenario last week, where if you have the dilemma of a patient as hypoglycemic, glycemic proven, and patient is also in shock, now you only have one line. You're struggling to get the second one, but you have only one line. How do you deal with that?
Okay.
So what should you do?
Okay. This is what I will do. Since the glucose is pushed, right, and the volume is usually less than that of the saline, I will give, in this case, what is the weight of, did they give us the weight here?
So it's an infant, so it should be less than 10 kg.
Okay, so I'm given, let's say the child is 20 kilos. I'm given 40 cc's of D5 push because the hypoglycemia can damage the brain. And as soon as I push that, then the one that I have to give slower is the saline. Then I'll give the saline next. Because the interval between correcting the hypoglycemia and correcting the hypovolemia is in the order of seconds. But I cannot be giving saline to this child for 5 to 20 minutes while the child is hypoglycemic. You see what I mean? Because the hypoglycemia can cause brain damage and seizures. So if I'm in that scenario, I push my glucose and follow immediately with my saline in that order. Is that logic clear?
Yes, it makes sense. But because of the rebound hypoglycemia, one still needs to struggle to get a second line.
Oh, well, definitely you will. If you push, say for example, I like the fact that this is a practical question. If I'm in this situation, I push my glucose and I give my bolus fluid, and then I will hang a fluid that has D5 half normal saline or D5 normal saline at maintenance. That doesn't mean I cannot stop in between and be pushing fluid. So I push my 20, hopefully when you push 20 cc's per kilo in this child, if the child is not having ongoing loss, i.e., it's not like the child is having diarrhea while maybe the kid was in hypovolemic shock, that 20 per kilo given rapidly should at least increase the blood pressure, and then you put on your maintenance fluid, which has dextrose in it, if you are worried about rebound hypoglycemia, while you are looking for another IV line. So that's what I think we can do in this scenario. But the main teaching point here is that when you are resuscitating a child, do not use hypotonic fluid because you can cause rapid cerebral edema if you do that. And it has, I've seen that happen even here in pediatric patients seen by adult physicians. The glucose is low, I'm giving D10. So no, you have to use isotonic fluid. So in this case, you need to treat the hypovolemia and treat the hypoglycemia. Okay, if there are no...
Thank you. So
Yeah.
number 8.
Number 8.
Yes.
Excuse me, sir.
Yes.
Thank you very much for your lectures. Please, I just want to ascertain, after correcting the hypoglycemia with the dextrose at 2 to 4 mils per kg, can't we add some maybe 50% dextrose to the isotonic saline, for that's add it as we are given the normal saline. That is, maybe make it up to 10% days through, so that there will be maintenance of the intravascular volume, as well as giving some glucose at the same time to avoid rebound hypoglycemia.
Okay.
Wouldn't that work?
I don't, the issue here is the rate of administration, the rate, how fast you are giving it, in addition to the composition of the fluid. Anytime you are giving a hypertonic fluid, you want to not, for example, this 2 to 4 mL per kilo, because of the volume, if you push that, it's of no consequence. But if you add it to your isotonic fluid and you push that into a patient, you might run into